we're going to report data from the clinic that I've been running for the past 2 years. So just to orient you all a bit, I'm sure you know what the United States looks like, but here is where we're located in Pennsylvania. Geisinger is part of a system that covers about 2/3 of the entire state of Pennsylvania, and we're quite a large system. Goodness. And we have multiple hospitals within our system, and we also have, we're a little different in the states in that we do also have our own healthcare plan, and so we are an integrated healthcare system. We we own our own providers as well as hospital systems, and we also have our own health plan, as I stated. So a little bit about what pharmacist-run medication therapy disease state management clinics. We have a long history of running them in our system. We started out in 1996 with 2 pharmacists running an anticoagulation clinic only, mainly in cancer patients is what it started with, but then it has exponentially grown, and now we have 52 pharmacists working in tandem with physicians in 47 clinics system-wide. We manage a wide variety of different disease states. We manage anemia, anticoagulation, hepatitis C patients, diabetes, hypertension, geriatrics. We also do multiple sclerosis, heart failure, and then hematology oncology. It is exponentially growing, and we are slated to open 2 practice sites within the next 2 months as well, so we continue to keep operating. So what exactly is collaborative practice when I say this? In the US, it depends on the state, but pharmacists can work in tandem with physicians under a legal agreement called a collaborative practice agreement. And it's a legal contract that the pharmacist can manage patients for specific disease states. And so they have to show competency in this disease state that they're managing, and in that competency that would either be some sort of professional certification. We also have internal certifications that we update annually for all of our pharmacists that would be managing patients. In the US, only 48 states allow collaborative drug therapy management, so it is not an entire country run sort of system, but it is in 48 states, and Pennsylvania is one of them. In our Commonwealth, at our health system, pharmacists are able to order lab tests or EKGs. We can modify current medication regimens, or we can add on new medications as long as they're within the scope of the practice of the patient that we're treating. So we don't diagnose patients, we work within a diagnosis, but if a patient has diabetes, for example, and they need lipid medication along with their diabetes medications, then that is something that we are able to help with as well. We manage our patients through either the phone and face-to-face visits, or we are using we call a patient portal, so it's online. We can send secure emails to patients, and they enjoy that a lot. So specifically, what is our hematology oncology MTDN clinic? The services that we offer to our patients are, we discuss and educate patients on potential adverse effects of their medication. This clinic specifically is looking at patients on oral chemotherapy agents, and so we also can then manage current adverse effects on the medications. So for example, if the patient is having some sort of side effect, we can add on supportive care medications. So if they're on Tarceva and they get an EGFR rash, then we can add on clindamycin, since we usually use things like things to treat acne for those sorts of EGFR rashes. If the medication has a tendency to cause nausea, we can use ondansetron. And if the patient gets hand-foot syndrome, we can suggest Uri cream. In the US, some percentages of the Uri cream are prescription only, where other ones are not. And then if the patient is having stomatitis from everolimus, we can also send a prescription for a dexamethasone rinse. We also, according to the drug manufacturer's suggestions, we make sure that the patient is compliant with testing guidelines. So we make sure that if a patient is started on nilotinib, they're getting a baseline EKG as well as one 7 days after starting therapy, and then periodically thereafter. One thing we have noticed is that a lot of our TKIs do have a tendency to cause hypothyroidism, and so we do test for hypothyroidism, and if needed, then the patient can be started on medication. Abiraterone has a very strict guideline on LFT monitoring. The manufacturer suggests LFTs every 2 weeks for the first 3 months of therapy, and then once a month thereafter. And also we do a lot of hydroxyurea monitoring, and so that's dependent on the counts. That's weekly, once a month, depends on the patient. We also have to talk about compliance with our patients. We know that when they come into the clinic and they receive their IV treatments, that we know that they're getting it because they're physically there. When they're taking these oral therapies at home, then are they really taking it or are they not? And so we utilize open-ended questions to talk to our patients about these therapies. So how many pills are you taking is a common one, particularly because a lot of these oral therapies come in multiple pills as for the dosage form. So for pazopanib, the 800 milligram dose is actually 4 tablets. And so how many pills are you taking? How many times a day do you take your medication? A lot of these medications are twice a day. So that could be capecitabine, you're taking it twice a day after meals. And then how do you take it too? A lot of these medications require empty stomachs because of the acidic nature that the drug needs to be absorbed. And so we need to make sure that they're taking it appropriately. And also what's kind of interesting about the empty stomach thing is it seems that drugs are actually more absorbed with food. And so a lot of the drug manufacturers have stipulated that they would like an empty stomach because that way it's a more consistent absorption over time. One of the things that we really do to make sure that there isn't any drug-drug interactions, a lot of these drugs have very interesting drug interactions that you don't necessarily think about as a regular clinician. And so we do a full medication history with our patients to see what they're taking, and that could be their the over-the-counter medications, their herbal medications, and just trying to make sure that they're going to be able to get the full benefit of the therapy, and that the therapy isn't going to harm them in any way that we can hopefully avoid. As I stated before, a lot of acid reducers interact with a lot of our oral medications because they do need an acidic environment to be absorbed. And we are finding too that there's some information about certain antidepressants in patients taking tamoxifen, and that there is a potential for perhaps that a patient over time may not get the full benefit of the tamoxifen depending on what antidepressants they are on, and they have a potential for relapse. And so definitely want to try to avoid that if we can. We also have a lot of patients who get clots, so they're on warfarin. And so we're trying to make sure that you're not going to increase their INR at all, and that's usually the drug interaction with these. And then also, a lot of these combination TKI medications have a VEGF component to them, and a lot of that VEGF can cause crazy hypertension in patients. It seems to be that people who have baseline hypertension are kind of the ones that have the more problem with the hypertension afterwards once we add on a VEGF inhibitor. And so really trying to kind of make sure we have an awareness that, okay, you're going to need to make sure that you take your blood pressure at home, and if they do, then we can add on extra medications as well for that. The type of patients that we see in this clinic, any patient that we're seeing in our HEMONC clinics are eligible to be followed by the pharmacy clinic. They are referral based at this time. However, in the future, we'll be using our electronic medical record to identify patients. And in our system, we have 2 hospital-based clinic groups as well as 6 community and outreach clinic groups. So it's quite a number of patients that we are eligible to follow. At this time, the patients are contacted via telephone. A lot of our patients are very rural, and it can be up to an hour or 2 hours by car to drive to one of our facilities. And my philosophy is that I'm not going to make somebody drive that far if I'm just going to call them to say, hey, how's it going? So we try to make things as convenient as possible for the patient. We do document everything, so we have an electronic medical record. Everything gets put into the chart. And each drug does have a specific note that we develop that has specific side effects that we're looking for, either very common or very serious. And then we also develop laboratory testing guidance based upon the different manufacturer recommendations. Currently, we're staffed by 1 pharmacist, myself. We did just hire somebody new, so I'm very excited to have some help. And Hopefully this person will be fully running by the new year. So here's some data looking back. We've been running now for 2 years, and in that time frame, we found 486 patients were followed. Of those patients, 66.7% had solid tumors. The top would be colorectal, breast, glioblastoma, prostate cancer, and renal cell. 20% were what I kind of consider non-malignant or pre-malignant hematology patients, so that would be essential thrombocytosis or polycythemia vera. We have a big cluster of these type of patients in our area, so we do have quite a number of them. We also have ITP patients as well as patients on iron chelating therapy. 13.4% of patients then were for malignant hematology patients, so our CML patients, our CLL patients, as well as multiple myeloma. Currently, so we have patients that were current patients of the clinic as well as patients that have been discharged from our care due to various reasons. And so patients who are currently a part of our clinic, they were part of our clinic for an average of about 7.8 months. And if you were a current patient or an inactive patient, we found that patients were contacted about 2.7 times per month. So almost about 3 times a month. So we're in contact with these patients quite often, and so the patients feel like they are not being left to drift a bit. If you were a patient who was discharged from the clinic, they were under the care of the clinic a little less time, about 5 months, but also were similarly contacted about 3 times per month. The reason that patients were discharged most commonly were due to progression of disease, so their therapy was changed. Also, another most common reason would be that the patient had finished their treatment course, so they were on a treatment course of Xeloda, and then they with radiation, and so that treatment course had finished. Or we have a fair amount of patients with glioblastoma, and so they received their 12 months of Temodar therapy, and then were finished. Patients who took the medication or who were followed by the clinic for less than 1 month were found that the reason that they stopped taking the medication were due to intolerance or adverse drug reaction, only second most commonly. So still patients who had progression of disease were still most likely to be discharged from the clinic within the first month of therapy. In this time frame, we monitored 53 different drugs. That's quite a number of drugs. We follow all comers. Interestingly, about half and half were tyrosine kinase inhibitors versus non-tyrosine kinase inhibitors. The top tyrosine kinase inhibitors that we follow would be everolimus, ibrutinib, imatinib, pazopanib, or sorafenib. The non-tyrosine kinase inhibitor drugs would be capecitabine, hydroxyurea, temozolomide, abiraterone, or enzalutamide. Our most common medication that we follow would be capecitabine, and that's mainly because of the various amounts of different ways that we can use the medication. We also did assess compliance, and most patients were reported as being compliant with therapy. We did use a medication adherence questionnaire, and the patients were we discussed with the patients, how they were taking the medication and if there were things that we could do to help the patient become more compliant. In general, I feel like most patients are compliant with therapy. There are studies that show that, particularly in breast cancer patients, when they're taking their 5 years of tamoxifen, as time goes on, they use less and less adherent to their medication. However, with some studies, we found that more frequent contact with patients to kind of talk to them and discuss with them the importance of taking the medication, those more contacts, those patients tend to be more compliant. And you can also figure out if there are issues, particularly side effects, if the patient does not want to continue to take the medication. One of the things that we did look at was that we tried to see what the provider and the patient reaction to this clinic was. So we did survey our providers who utilize this clinic. So we sent out 22 surveys and received 18 responses. It was a Likert scale of 1 to 5, and it was a 12-question survey. The average score for all responses was 4.86, so it was a very highly regarded clinic. And some of the questions that we answered were things like, the pharmacist always notifies me if there are problems or concerns regarding the care of my patients and that I refer to the clinic. Some comments we received from the surveys were things like excellent service, very helpful, we have a good rapport, the best service we have added, the pharmacist is a superb resource for the care of our patients. So very highly regarded clinic from our providers. From our patients, we sent out 193 surveys to the patients who are currently active within our clinic. And it was a 10-question survey, however, one question was removed due to incorrect wording. This also was a Likert scale of 1 to 4, and the average score for all questions was 3.6, so also, again, highly regarded by the patients. We also talked to the patients and asked them how long they had been part of the clinic, and about 48% of them reported that they had been a part of the clinic for over a year. Some sample questions that we asked to these patients would be things like, I feel that attending the NTM clinic has helped me to better manage my medications, understand and control my medical conditions. So some interesting responses we received from our patients. So I appreciate their phone calls to check on my progress with the drug. Their concern is greatly appreciated. The calls I receive from the pharmacist are always very helpful. She answers my questions and answers some questions I didn't know I had, and her upbeat call is always a day brightener. And also the pharmacist provides good suggestions to decrease side effects of the chemo. So that's it for me today. I'd love to entertain any questions or comments.
Thank you very much for your presentation. I have just only one question. Do you use the therapeutic drug monitoring to avoid drug-drug interactions? This phenomenon is very common among the anti-cancer drugs. So some drugs can increase the metabolizing enzymes and other drugs can inhibit the metabolizing enzymes. So one of recommendation to measure the blood concentration of the drug or its metabolized to avoid side effects and do adjustment of the optimal therapeutic dose. So you conducted the therapeutic drug monitoring in your lab?
We do not do usual levels of the drug concentrations in patients. We find that most insurance, we have to deal with insurance companies, and most insurance companies would not pay for that sort of testing. I do feel, though, that we can, in a way, determine what the drug levels are based upon patient side effects, and that's why we do have very close follow-up with patients to talk about with them potential side effects and if they're experiencing those side effects. We do find that even with dose reductions in patients, we can get still pretty good results with therapy.
You depend only on the side effects, but sometimes the drug concentration will be low, so the efficacy as anti-cancer will be low.
Correct, yeah.
Thank you very much for the presentation. I work in the UK, and it's a good thing that pharmacists are beginning to do this kind of work, because in England it's the specialist nurses that do it, and a part of the workforce challenge that we have now is how to create specific rules for the pharmacists and for the specialist nurses, and to know how things get done by the same thing by two different people. Yeah. So do you have any specialist nurse cadre? And if you do, what do they do?
Compared to this, yeah. We this type of service is fairly new within the U.S. The whole idea of this medication therapy management with the collaborative practice with the physician is still a newer concept, particularly in the oncology setting. It's very well utilized in anticoagulation with Coumadin clinics and things like that, but expanding into more of a disease state model is kind of a newer thing. We do have nurse specialists as well, and they work more closely with our physicians, and we kind of utilize them to more on the IV medication side, and they help with, since we have to deal with insurance and things, we have them help try to determine if we can get coverage through the insurance company. That's what the nursing, what they kind of do. They also do education as well, and so we're kind of working in tandem, and so we can have patients who are both on IV therapy as well as oral therapy, and so then I can work hand in hand with this nurse specialist as well. My approach to the nurses when we first started this clinic was to try to help them, because obviously our nurses you would have one nurse for multiple physicians, and so it's quite a high workload for them. And so trying to utilize the pharmacists in a way to help kind of take some of the workload off of them, they were very happy about that.